For that very nice introduction. And I'm going to say good afternoon to everyone because it is just noon here in Toronto as well. So hopefully everyone can see my screen and you can go ahead and get started. So when Dr. Wobker approached me for the presentation today, I was originally going to give a talk on prostate cancer, but I decided instead to do sort of a potpourri of topics, so updates in bladder pathology. It's a pretty generic title. So before we get started, I do want to share a little bit of data with you about where I practice. So I practice in the province of Ontario in Canada. And on screen here, we can see our cancer statistics, which are produced by the Canadian Cancer Society. Now, similar to other cancer statistics elsewhere in the world, we're always lagging a little bit. So the most up-to-date figures I could get were the projected incidence for 2023. And when I was putting together this talk, I happened to come across some old cancer statistics I'd used in a much older talk from 2017. And what we can see here is in 2017, bladder cancer was the 5th commonest of the cancers that we find here in Canada. And if we fast forward to 2023, it's still the 5th commonest, but you can see we have had an increase in the incidence from just under 10,000 to over 13,000 cases per year. The other thing that struck me was that prostate cancer back in 2017 was our 4th commonest cancer. But when we go forward to 2023, it's actually increased to number 3 on the ranking. And perhaps that explains a little bit about why I feel all I do all day is sign out prostate cancer cases. And I do suspect if we look at this data in 5 years from now, we're probably going to see that moving up even further. So unlike other countries, particularly countries in Europe where your healthcare is delivered at the national or the federal level, healthcare in Canada is a little bit different. So for those of you that are not aware, we have a population of about 41 million people. And the country is divided up into territories and provinces. So up here we have our 3 territories, and then we have our 10 provinces running across from the west coast, BC, all the way across here to the east coast to Prince Edward Island. And of the provinces, Ontario is the most populous. So we have about 16 million people in Ontario. And in fact, about 8 million of those live in this area here, which is just around Toronto and Hamilton, which is called the Greater Toronto Hamilton area. So almost 1/5 of the Canadian population is concentrated in a very small area. So why am I telling you this, apart from the fact it might be interesting, is that because our healthcare is delivered at the provincial level, there will be significant differences in terms of accessibility to drugs for patients, depending on what province they live in, and also from the pathology perspective in terms of what biomarker or molecular testing is available. So although Ontario has Quebec and Manitoba as its neighbours, the testing strategies and the molecular availability and the biomarker tests will be different. So when I speak throughout this talk about what testing we do, it's very Ontario specific. So as I mentioned at the start, I was going to talk about prostate cancer, but then recently we had a webinar from Ontario Health Cancer Care Ontario, which is our provincial body. And this is a little bit alarming, but essentially what's been happening here in the province is we are seeing a declining survival from bladder cancer. So if we look at this graph here, you can see that data from 1984 and 2018, if you follow a multitude of cancers, the survival rates are all trending upwards. Bladder cancer is in fact the outlier. It's highlighted here with the yellow line. It's trending downwards, and that is concerning. It's concerning because we know the survival of patients with metastatic disease has doubled during that time point. And when we think about bladder cancer, we think of it in 3 buckets. You've got the non-muscle invasive cases, you've the muscle invasive cases, and the metastatic cases. And a lot of what I'll talk about in the second part of the lecture around biomarkers and molecular testing will, I think, at least explain why the survival rates have doubled for metastatic, but it does mean that we are not doing so well in either the non-muscle invasive or the muscle invasive setting. There's a variety of different reasons that could be. Some could be pathology specific. A lot of them are infrastructure and resource specific, but it is certainly a very hot topic here in Ontario. With that in mind, I thought I'd talk about some updates in bladder pathology. So we're really going to cover, as I said, a potpourri of topics. There's going to be 3 topics we look at. We'll do some overview of the updates that came out from the ISUP Florence consensus meeting last year in September 2024. And this, and again, a lot of that will be quite specific to where I practice here in Ontario. And then for the third part of the lecture, we're going to just cover very briefly a fairly newly described entity, which I think is an important one to bear in mind in your differential diagnosis of high-grade urothelial and high-grade prostate cancer. So back in September 2024, the ISUP held a consensus meeting. That was just after the European Congress of Pathology in Florence. And perhaps many of you on the call today were either at that meeting, but certainly many of you would have participated in the pre-meeting survey. So typically what happens when there's a consensus meeting is we circulate a list of survey questions to the ISUP membership to gauge their opinions and thoughts on a variety of different topics, and that helps to inform what the working groups will work on and present on the day of the consensus meeting. So this was a pretty big undertaking. The consensus meeting was an all-day affair. We had 5 working groups. No surprises, working group 1 was, of course, prostate, but working group 2 was the urinary bladder. And the theme of this consensus meeting was looking at pre-malignant and precursor lesions. The work from the bladder group is now available online, and I have included the just a snapshot of the paper here. So it's up online on PubMed, and it's online for the American Journal of Surgical Pathology if people are interested in reading about it afterwards. So essentially, what the bladder group decided to do was to look at the pre-malignant and precursor lesions and dividing them into four different categories. So when we think about entities in the bladder, we can put them into a category of something that's flat, something perhaps that's papillary, that covers mostly the urothelial lesions. You can also have glandular entities and squamous lesions as well. And we subdivided the working group into individual subgroups, and Gladell Painter led the flat working group. I led the papillary group. Antonio Lopez Beltran looked after the glandular lesions, and Donna Hansel after the squamous lesions. So what I'm going to present today is just a small part of some of the topics that were covered. Obviously, we can't cover it all today. So I've chosen to look at dysplasia, papillary hyperplasia, intestinal metaplasia, and keratinizing metaplasias as some of the subtopics that were covered. We'll do a quick overview of terminology and why terminology matters, some of the diagnostic criteria, and we'll examine some of the evidence for their pre-neoplastic or precursor nature. So we had 49 questions, I believe, for the bladder portion of the pre-meeting survey. So thank you for those that did complete it. It was a lot of work. This is one of the questions from the flat subgroup, which was around terminology. So from time to time, you will see flat lesions that are atypical, but perhaps they don't quite meet your criteria for carcinoma in situ. So what terminology do you use to describe these? And you can see here that the light blue or the turquoise bar was the favorite terminology, which was the terminology of urothelial dysplasia, which was used by almost 67% of the respondents to the survey. So let's take a look at this. So on screen, we have 2 images. These are flat lesions of the urothelium. They don't look like normal urothelium to me. What we can see is there is some preservation of the umbrella cells on the surface. But when we take a look, we're starting to see a little bit of disorder. So by disorder, the cells are mostly polarized. And by that, I mean they are pointing vertically or oriented perpendicular to our basement membrane. But we can see a little bit of variability in the size and shape of some of the nuclei. They are starting to butt up against their neighboring nuclei, and the chromatin is a little bit altered as well. We can start to see some of these prominent nucleoli. So not entirely normal. So what is it not? So here's an example of normal urothelium on the left-hand side of the screen. And if everything looked like this, wouldn't life be wonderful? And on the right-hand side, we have the other end of the extreme, which is carcinoma in situ. So if you look at the example of CIS, you can see we have marked variability in terms of the nuclear size and shape. We have pleomorphism. You can see we're starting to lose cells. They're starting to shed off the surface here. And you can see the cells are no longer respecting their neighbors' boundaries. They are starting to get jumbled up, and they're not vertically oriented perpendicular to that basement membrane. So the examples I showed you in the preceding slide are not normal, and they're not carcinoma in situ. There's something in between. And what is in between? Well, you can have reactive atypia, but typically reactive atypia will show some degree of inflammation, and there'll be a history of why it should be reactive. And if it's not a reactive atypia, what is it? Well, it's something atypical, and there are various terminologies that have been used: atypia, NOS, atypia of undetermined significance, and of course, dysplasia. So if we take a little walk through the terminology and classification of flat lesions, and this is a really excellent paper from Gladder Painter that was published a couple of years back in Modern Pathology, I've tried to put red boxes around where the word dysplasia appears. And we can see it's been in use in the Bladder lexicon since the 1980s, so for about 4 decades. The problem with dysplasia, while we all have an idea in our head of what it might mean, is that really we don't have very good, robust diagnostic criteria. And essentially, when we talk about dysplasia, we are talking about an entity or a lesion where the cytology and the architecture falls short of CIS. So essentially, you do not have the criteria that would be sufficient for a diagnosis of CIS. And similar to what I showed you in those pictures, you often see the urothelial still has preservation of the umbrella cells, but we do see some atypia with crowding, loss of polarity, enlarged nuclei, etc. Mitoses are typically not that common. So there are arguments for retaining the dysplasia terminology, and there are arguments why we should no longer use it. And again, this is taken from Gladder Painter's paper, but essentially some of the arguments about why we may wish to retain the dysplasia terminology are because we will often see molecular changes in dysplastic lesions that you will see in carcinoma. Dysplasia has the potential to progress, and in similar to other organ systems, pathologists use the word dysplasia in the head and neck. They use it in many other organ systems. So it's familiar terminology to pathologists and also to clinicians, and it helps designate a lesion where you're a little uncertain or maybe borderline. As I've already alluded to, some of the challenges are the poor diagnostic reproducibility, and what is the clinical significance of secondary dysplasia when you have a diagnosis or pre-existing diagnosis of a carcinoma. And also, we don't really have supportive ancillary testing. And with this in mind, the last WHO Blue Book that came out in 2022 no longer had a separate category for dysplasia. And the reason being that there's no clearly defined histologic criteria. It is still referenced, and it's under the CIS section, and says that if a lesion falls short of CIS, you could use the terminology of dysplasia. So is it really a precursor lesion? And a lot of the data around this is certainly a bit older. It's a couple of decades old now. But essentially, I've put together 3 of the studies that have looked at this question. 2 of them are from our current ISUP president, Professor Liang Cheng. And in these studies, which followed patients with dysplasia, essentially there was progression seen in anywhere from 14 to 19% of patients. So progression was either to carcinoma in situ and in some cases to invasive cancer, which certainly suggests it may be a precursor lesion. So what can help? Well, of course, we can do molecular, we can do biomarkers in the form of IHC. Again, the data shows that in patients that have been studied from a molecular perspective, that you will often find changes in the quote unquote normal appearing and dysplastic appearing areas that are similar to what you will find in the associated carcinomas. And later technology, as things have moved on and we're doing NGS analysis, etc., have looked at that from the TERT perspective as well. From an IHC perspective, CK20, Ki67, P53 are the markers most commonly employed. There are other ones. And essentially, they show that you will see abnormalities in these markers in dysplasia as well as in carcinoma in situ. Unfortunately, it's not possible to use them to distinguish between dysplasia and carcinoma in situ. That is still essentially a morphologic call. So dysplasia terminology is certainly in use by GU pathologists. Up to 2/3 of those surveyed said they use it. We feel it's likely a risk factor or precursor for carcinoma in situ. We know that there is an issue with diagnostic criteria, which means we have poor inter-observer reproducibility, and molecular and IHC are not necessarily diagnostic. So the summary recommendations from the Florence group that were looking at the flat lesions was that the term urothelial dysplasia should be used to diagnose a low-grade flat urothelial neoplasm. If it's very high-grade, it would be carcinoma in situ, and that we do need to really work on developing more robust criteria to enhance our diagnostic reproducibility. Okay, moving on from the completely flat lesions, we have more urothelial lesions on screen here. Hopefully you can appreciate that these lesions have a little bit of a wavy or a tented appearance to the surface. The urothelium looks fairly bland, and there's a little bit of vascular congestion, I think, around the base. So again, what are we dealing with here? So again, bland thickened urothelium, no real atypia, no fibrovascular cores. It has this undulating appearance, almost like someone got a forceps and pulled up a piece of urothelium, moved along another couple of microns or millimeters and picked up another piece. So it has this tented appearance. The problem is, while it's tempting to ignore it, is that someone did actually see this at cystoscopy and thought it looked a bit abnormal and took a biopsy. And now that means we didn't create it. It's not an artifact. It's something real, and we do need to put a name on it. When we're out of the flat lesions, we start to verge into the territory of papillary lesions, and there's a number of differential diagnostic considerations, which ranges from something that's very innocuous, like a papillary cystitis, all the way up to a papillary urothelial carcinoma. So if we look at some of the examples here, we can have exophytic papillomas, which often have these very prominent unfloured vacuolated cells, something to just bear in mind. You don't overcall that as atypia. Papillary polypoid cystitis usually starts off as a polypoid lesion, where we see these club-shaped excrescences into the bladder lumen. We have lots of edema, normal overlying urothelium, and over time this often undergoes fibrosis, and we end up with these more finger-like fibrotic cores, the papillary cystitis. Papillary urothelial neoplasm of low malignant potential, hyperplastic urothelium, but you should see a true fibrovascular core, and then papillary urothelial carcinomas, which can be either a solitary lesion or an entire carpeting of the bladder lumen, and these can be low grade or high grade. So there's sort of the differentials in the papillary world. So as part of the pre-meeting survey, we did ask all of the ISUP membership about this and said, when you have a bladder sample that shows this thickened urothelium, which is bland and a little bit tinted, but you don't have papillae, how do you report? And you can see almost 65% or 63% of the respondents said they use the term papillary hyperplasia or papillary urothelial proliferation with certain malignant potential, and some people give very descriptive reports. And some people will talk about an incipient or evolving low-grade papillary urothelial carcinoma. So terminology. Papillary hyperplasia was terminology that appeared in the WHO 2004 Blue Book, and it was used to describe the situation we've just alluded to. In 2016, the terminology changed, and this term UPUMP, or urothelial proliferation of a certain malignant potential, appeared. And this is a great descriptive terminology because it tells you exactly what you're dealing with. It is a urothelial proliferation, and it is of uncertain malignant potential. It does have the potential to go on and become something nasty, and that is a great description. Unfortunately, UPUMP is a little bit of, it's quite wordy, and in some ways it does sound a little bit about the aforementioned pun lump, and clinicians may have some difficulties, I think, distinguishing between the two, particularly if you call something a papillary UPUMP. A PUPUMP sounds like pun lump. In WHO 2022, which is the latest WHO Blue Book, we don't have those terminologies anymore. We explain a little about that on the next slide. So, in terms of what you're going to do with these lesions, you need to know a little bit about the clinical history. Is there a prior papillary urothelial carcinoma? And if so, could this just be from the edge of it or the shoulder lesion? I've taken this diagram here from Gladell Painter's PowerPoint that he used at the Florence meeting to essentially illustrate the concept of a shoulder lesion. So you have this papillary exophytic lesion, and then we have this slightly hyperplastic, maybe bumpy looking area on the side, and that represents the shoulder. So is it possible that essentially what we're just seeing is the shoulder lesion? Yes, it is possible. If you have a true fibrovascular core along with the hyperplasia, you're not dealing with a papillary hyperplasia. That brings you more into the realm of the pun lump or the papillary low-grade urothelial carcinoma. So from a histologic perspective, if you have a lot of cytonuclear atypia, architectural disorder, proliferation, fusion, and suprabasal mitotic activity, it really takes you out of that category of papillary hyperplasia. So in the updated WHO Blue Book, the rationale for removing hyperplasia and pun lump was that this may represent a shoulder lesion from a prior resection of a prior low-grade papillary urothelial carcinoma, which indeed it can do. What is the evidence for its preneoplastic nature? Well, there's been evidence from a molecular perspective and also from a clinical follow-up perspective. And essentially what these studies outlined in the tables on screen here show is that if you have depending on the molecular technique used, and they've evolved over the years. But if you look at patients who either have simultaneous or consecutive papillary urothelial carcinoma in conjunction with papillary hyperplasia, that in many of these patients you will find the same genetic alterations. In terms of the clinical follow-up, many patients either with papillary hyperplasia have had a prior history or have a concurrent history of a papillary urothelial neoplasm. So together, this evidence suggests that there is a very strong genetic and temporal association between this entity of papillary hyperplasia and papillary urothelial carcinoma. And not all cases will have a prior or coexisting papillary tumor. And the respondents to the survey and at the in-meeting voting, many people did consider this papillary hyperplasia or papillary UPUMP in the 2016 terminology to represent a potential precursor. So the resulting recommendations from the papillary group were that we should adopt uniform reporting terminology, and it appeared that the preferred terminology was papillary hyperplasia, and that papillary hyperplasia could be designated as a potential and likely precursor to papillary urothelial neoplasms. Moving on to the glandular lesions, I think this lesion on the top left is very familiar, cystitis cystica. It's a common reactive process in the bladder. Very occasionally, it can be extremely florid and produce a little nodular bump, which may actually be sampled as something suspicious at cystoscopy. Much less common, we have intestinal metaplasia, where you start to see these goblet cells appearing. And even less frequent is when you have intestinal metaplasia with dysplasia. And then, of course, you can have a frank adenocarcinoma. So this is the spectrum, really, of some of the glandular changes you can see in the bladder. And as we know, primary bladder adenocarcinomas are always very tricky, and it is a pitfall because you have to decide, is it definitely an adenocarcinoma, or is it a hybrid urothelial carcinoma that just has a lot of glandular differentiation? Or indeed, has it come from somewhere else? So always the challenge is excluding a GI or a gynecologic malignancy in the bladder. And that can be challenging because the IHC often is not helpful, and it does rely on some clinical and radiologic features. So the clinician does have to be involved in that as well. So the reactive changes we've talked about are the cystitis cystica glandularis. It's common, as I said, intestinal metaplasia, not common. Certainly in my practice, where I tend to see it is we have a large trauma reconstructive program as well as our oncology program at Sunnybrook, and we see a lot of pediatric patients who've transitioned out of pediatric into adult urology care, and they've had multiple surgeries, things like bladder exstrophies or augmentation cystoplasties done. And they often tend to be the patients where I think you see these intestinal metaplasias. Intestinal metaplasia with dysplasia, as I've already said, is rare. And we've touched on adenocarcinomas, and you can have various different forms as outlined in our WHO Blue Book. So these are some examples here of florid intestinal metaplasia with some dysplasia and an adenocarcinoma, and these images are courtesy of Professor Antonio Lopez Beltran. So we did ask people in terms of what they thought about the precursor nature of some of these glandular entities. Most people did not think that cystitis cystica glandularis without intestinal metaplasia was a precursor for bladder adenocarcinoma. However, many people did think if you had intestinal metaplasia with dysplasia, that was a potential precursor to bladder adenocarcinoma. And I think that makes sense from a pathology perspective. We always think about the progression from normal to metaplasia to dysplasia, in situ cancer, and invasive cancers. Another question was around the terminology for these lesions, and what was, I think, the favorite terminology for these glandular lesions was cystitis glandularis, which we already use, with or without intestinal metaplasia, and that could have dysplasia, which would be called low or high grade. So what is the evidence about the precursor nature? So we have some clinical and molecular studies on screen here. So from the clinical perspective, it's interesting. The largest study, which had 53 cases that included adult and pediatric cases of intestinal metaplasia with follow-up, found none of these patients developed adenocarcinoma. Yet many of the other studies that are listed there, patients who had intestinal metaplasia with varying forms of dysplasia did show either concurrent adenocarcinoma or some of them, particularly the earliest study in 87, did show subsequent development of cancer. From the molecular perspective, again, the molecular techniques have varied as we moved on to the 2020s. We're starting to see some NGS techniques being applied, and what has essentially been shown is these cases with intestinal metaplasia often do have oncogenic variants that we would typically see in adenocarcinomas and urothelial cancer. So the conclusions from this part are that most people will consider intestinal metaplasia with dysplasia a precursor to adenocarcinoma. We know that it often occurs, you see co-occurrence of intestinal metaplasia with adenocarcinoma, but it doesn't seem to be as strongly associated from the clinical follow-up studies with subsequent development of adenocarcinoma. And the recommendation is that if there's dysplasia in these lesions, it should be noted and graded using the low and high grade dysplasia categories we're familiar with from other organ systems. Then finally, we have the squamous lesions, and squamous change in the bladder is not uncommon. Again, I often see this in terms of our spina bifida patients and patients who've had spinal cord injuries. Just a word of caution, I think most people are aware that you can see squamous epithelium in the trigone in the female bladder. So a level of situational awareness about where your sampling is from is always important in bladder pathology. Where things become interesting is when you start to see metaplasia with keratinization. And by that, what I'm referring to is we have a squamous epithelium and we have this dense eosinophilic layer of keratin at the top. And this is keratinizing squamous metaplasia. You can also see non-keratinizing squamous metaplasia. And you can also have entities such as verrucous hyperplasia, where you see this church spiring appearance with this heaped up hyper and parakeratosis. And then similar to what we've already described, you can see dysplasias, in situ cancers, and obviously invasive squamous cell carcinomas. So from the ISUP surveys and the consensus meeting, we asked people about their thoughts on non-keratinizing and keratinizing squamous metaplasia. Most people do not think non-keratinizing squamous metaplasia was a preneoplastic lesion. Different story for keratinizing. Most people are very keen to make sure they recognize and report keratinizing squamous metaplasia in their routine reporting. And many people, almost 3/4 of those, said they would comment on the presence or absence of dysplasia. And then they also use the low grade, high grade nomenclature for the dysplasia as well. Again, somewhat limited in terms of the studies that are available. Most of them are fairly contemporary in the last 2 decades. So what you can see here is that most of the studies that have looked at squamous cell carcinoma of the bladder found that many of the cases already had background changes in the squamous nature, such as squamous metaplasia. Some of the patients had squamous dysplasia, and some had verrucous hyperplasia, again suggesting that there is a relationship between these squamous preneoplastic lesions and squamous cell carcinoma. So really the conclusions from the squamous portion of this Florence consensus meeting was that keratinizing squamous metaplasia and verrucous hyperplasia, we should be able to identify it. It should be reported. That dysplasia should be graded. And that keratinizing squamous metaplasia with high-grade dysplasia is likely a precursor to squamous cell carcinoma. And these were the recommendations that are in the AJSP article about reporting keratinizing squamous metaplasia and the grading of squamous dysplasia. So if you are interested, you can obviously have a look at that article. And we do have, I think in the supplementary part of that, there's the pre-meeting survey questions as well for those of you that may have not seen those when they were circulated last spring. Okay, we're going to move on to the second part of the lecture, and we'll talk a little bit about the targetable molecular alterations and some of the biomarker-driven approach in urothelial diagnostics. And some of this is, I've already said, is quite Ontario specific, but I think this in some way explains some of the great progression we've seen in the survival gains in the metastatic setting. And I think most people are very cognizant that for many, many decades, really systemic therapeutic approaches for metastatic and advanced urothelial tumors was essentially platinum-based chemotherapy. And that's a challenge because there's only so much platinum you can give someone in their lifetime. And when you consider a lot of these patients are older patients that have impaired renal function, again, platinum is hard on the kidneys. So you may be limited in the number of doses of platinum chemotherapy you can give. And as it happens, both the neoadjuvant and the adjuvant chemotherapy is platinum-based. So you can see there was a lot of excitement when things started to change around 2015 with this whole concept of that immune checkpoint inhibitors and PD-L1 testing, etc., when that came online. But since then, we have moved on and we have a couple of other molecular tests that we can offer, which can be helpful for some patients in conferring candidacy for treatment with different systemic therapeutic options. So one of the first of these tests was the FGFR testing, and FGFR is fibroblast growth factor receptor testing. And this really came about with the development of drugs which are FGFR, particularly pan-FGFR, tyrosine kinase inhibitors. And there was some promising data from phase 2 clinical trials, which showed maybe up to 40% of patients that harbored FGFR alterations could respond to these FGFR inhibitors. And this led to a phase 3 clinical trial. And I've put a quick snapshot of the publication, which was in the New England Journal of Medicine. And this was a clinical trial that screened over 7,000 patients. And this was a heavily pretreated patient population. These patients had all, I believe, received some form of immune checkpoint inhibitors and had also progressed. And amongst these patients that were screened, they found targetable or potentially targetable FGFR alterations in 16.6%. So in the trial, what they did was they divided patients into the treatment and the control arm. And the patients in the treatment arm, they had roughly the same number of FGFR alterations in both arms. The treatment arm received this FGFR inhibitor, erdafitinib, and the control arm received standard chemotherapy. And as you can see from the Kaplan-Meier curves here, there was a difference in the treatment between the median overall survival, which was almost 5 months difference, and the median progression-free survival, almost 3 months difference there. So in terms of metastatic urothelial carcinoma, that's quite an exciting difference in overall outcome. So what did they screen for in this particular clinical trial? They do DNA and RNA testings. They're looking for mutations, and they're also looking for fusions, so the mutations from the DNA and fusions from the RNA. And they were looking for FGFR3 and 2 alterations. So this was the clinical trial data. And we were given a provincial mandate, I think it was late 2022, to start FGFR testing in the province of Ontario for all metastatic and advanced urothelial tumors. So with this in mind, there are multiple testing sites across the province, but we decided to do a real world study looking at some prospectively collected data. I'm going to share that with you now. This was a study done at 2 sites. So Sunnybrook Health Sciences Centre in Toronto, where I practice, and my collaborator was Dr. Trevor Flood, based up in Ottawa at the Ottawa Hospital. And there are some similarities and differences amongst the 2 sites. Toronto has a larger population within the city compared to Ottawa, and probably a more diverse from an ethnic perspective. The testing strategy in Ottawa is centralization, whereas in Toronto we've multiple testing sites, and we currently test at Sunnybrook for probably in excess of 10 community partners in addition to our own work. So we had 366 of these prospectively tested cases. Not surprisingly, given that it's a urothelial population, it was a slightly older population and a predominance of males. Mostly lower urinary tract cases were tested. We did have some metastatic sites that were included. The testing was done on transurethral resection of bladder tumors for the most part, followed by cystoprostatectomies and then nephroureterectomies. So a lot of data in this table here, but just a high-level summary. Most of the patient population were over the age of 55. I've already said they were mostly male, mostly primary versus metastatic, and mostly urothelial histology. And within our urothelial cohort, most of those were pure urothelial carcinomas. We do have some components of divergent differentiation, and also some various subtype pathologies as well. There was a predominance of locally advanced disease. This is obviously taken from the surgical resection specimens, such that it was T3 or T4. Obviously, not all patients had nodes, because some of these were transurethral resections and metastatic biopsies, but of the patients who had nodes, there's about 10% node positivity. The metastatic site, well, he started with 55 cases, which is a decent number of metastases. When you break it down by site, it's hard to draw some conclusions. But what we did see was that there tended to be an enrichment in alterations in our lung versus the non-lung sites. And if we do lung versus other sites of metastasis, that was statistically significant. And I should have said at the start that actually both centers are using the same testing platform. So we felt it was really good to look at the data from the 2 sites. So we use Thermo Fisher and the Oncomine comprehensive assays for this particular testing. And as I said, it's DNA and RNA based. So really sort of high level, you can see an enrichment in the number of alterations detected when you move from the lower to the upper urinary tract, and from the lower urinary tract to a metastatic. We didn't see any difference in terms of the histology, but again, very small numbers of pure squames and adenos tested in this cohort. So we set out to analyze not only the actionable, but to look at all of the FGFR alterations that we could find. So in our full cohort of 366 patients, the top pie chart is all FGFR alterations. Not all of these will be actionable, because there's FGFR 1s and 4s, and also our actionable FGFR alterations, similar to what we saw in the clinical trial data. Also in this prospective real world data, point mutations are the most frequent alteration, followed by the FGFR3 fusions. And they're nearly always FGFR3 TAC3 fusions. And then I've just listed out here the tier 1, 2 FGFR mutations, and similar to what we know from older retrospective studies, the S249C is the most frequent point mutation. This work has just been published. It's up about 10 days online. It's been published in the American Journal of Clinical Pathology. So if you're interested, you can see the full article there. But essentially the take-home messages was that we found 59 patients in the cohort overall and there was 61 FGFR alterations. 49 were actionable, which gave us an actionable mutation rate of 13.4% in this real world cohort, a little bit lower than the 16.6% in the clinical trial. What we found is enrichment in FGFR alterations in lung metastases in the upper tract, and all of our actionable mutations were identified in the over 55 population. We didn't have many under 55s, but still we thought that was an interesting point. So moving on in terms of other biomarkers and availability, so this concept of ADCs or antibody drug conjugates have certainly taken off over the last few years. And an antibody drug conjugate is essentially a mechanism by which you can give a cytotoxic payload into a tumor cell by linking this cytotoxic entity onto a monoclonal antibody, which then recognizes a specific antigen on the surface of the cell or a specific protein. And four that we hear a lot about are Nectin-4, Trop-2, and HER2. So I'm going to just touch on these briefly. So Nectin-4 was something I think we saw a lot of publications, a lot of presentations at USCAP over the last few years. And this because it was the target that was used to deliver the drug enfortumab. And enfortumab is a drug that is now in widespread use. It has an FDA approval, so it's been given now in combination with the immune checkpoint inhibitor pembrolizumab as a first-line therapy for locally advanced metastatic urothelial carcinoma. And the initial clinical trial, which was published in New England Journal of Medicine in 2021, just looked at enfortumab versus chemotherapy. And we can see here there was a median overall survival benefit for the patients who received the enfortumab. And then a follow-up trial, which looked at this combination of enfortumab and pembrolizumab. And you can see we have increased separation of the curves. So significant difference between the outcomes in median progression-free survival compared to the chemotherapy arm, which is why it's now got its FDA approval. So what is nectin? Nectin-4 is a very heterogeneously expressed protein. You find it on a lot of urothelial carcinomas in the muscle invasive setting. Because it's so heterogeneous and most urothelial carcinomas express it, there's currently no requirement for us to do Nectin-4 IHC testing. You can do it, but it's not required for the patients to access the drug. There was an interesting study that just came out last year in JCO from Marcus Eckstein's group, which looked at Nectin-4 IHC using H scoring and also looked at Nectin-4 at the fish level. And they did find that patients who have Nectin-4 amplification may predict response or enhanced response to enfortumab vedotin therapy, but we are not required to do any testing at this point. Another ADC that received a lot of attention was Trop-2. It's another marker that's highly expressed in urothelial cancers. And again, no requirement to do IHC testing because it's nearly always seen there. There was a lot of interest in this. It got a preliminary approval for the drug therapy based on a phase 2 trial. However, the subsequent larger phase 3 trial, which was the Tropics-4, had disappointing results, including a lot of adverse reactions in the treatment arm, and the approval was actually withdrawn. There are some other trials ongoing looking at Trop-2, so perhaps it's something we will hear more about in the future, but certainly Nectin and Trop-2 not required for testing. ERBB2 or HER2 testing, again, lots of interest in this. As pathologists, we've been interested in HER2 expression in urothelials, mainly because it's been known for a long time that the micropapillary subtype does show an enrichment in these alterations. But really, this took off with the Destiny Pan tumor trial, and this was one of these basket trials which took lots of solid organ malignancies, and you can see the different cancers on screen here that were enrolled in the trial. Bladder was just one of them. And these were patients who had unresectable or metastatic tumor, again, heavily pretreated. And they tested them using HER2 IHC, and patients who had HER2 overexpression were found to have a good response to this antibody drug conjugate. Of the 41 urothelial cancers included, which is still a pretty small number, the overall response rate was 39%, and this is the urothelial component here in the orange bars on this screen. We can see here, while it overall was 39%, those that had HER2 3+ expression did have a better response rate than the 2+, and that testing is done using the HER2 antibodies and scored using the GI algorithm. As I've said, we already have a lot of interest in HER2 for some time in the bladder space because people recognize that you see an enrichment in these alterations. What's interesting about the bladder story compared to the much better known breast story in HER2 is we don't see the same tight alignment between the protein expression by IHC and the in situ hybridization. So, in breast cancer, if you have a 3+ HER2 expression, If you do fish, that's going to be very obvious and amplified. And if you do fish on someone who has a zero HER2 expression, you won't see amplification. And obviously, fish is done for the cases that are borderline or whatever in situ hybridization technique. And we don't see that same correlation in the bladder world. There's a lot of interest in developing our own scoring algorithms for urothelial. People have used breast scoring algorithms in the past. Now we're using the GI resection scoring algorithm. So I think there will be more to follow on that. And at our most recent consensus meeting in Vienna, that was held just last month, we did have some discussion around HER2 scoring and bladder cancer. So I think we will see more information on that forthcoming. Just to share a little bit of quick data, this is some ongoing work we're doing here at Sunnybrook. We have a large cohort of muscle-invasive bladder cancer patients that we've collected over the years. And we were able to do some testing with these antibodies, so the Nectin-4, TROP2, and using our HER2. And what was interesting was just to look at the spread of which patients expressed what in this cohort. I think we had 398 cases we were able to get results on. So what you will see is if you look at the TROP2, almost everyone is TROP2 positive. We did see increased expression of Nectin-4. So we actually use the H scoring, which, as you know, ranges from 0 to 300. And if you use 200 as a cutoff, which is sort of high expression, you can see that we only had 57 patients. We only had 27, 15, and 1, so just 40 something patients that had high Nectin-4 expression, but most patients were high on TROP2. And when we applied the scoring algorithm for the HER2, we had 57 patients that were 2+ or 3+ in this cohort. What's interesting is 15 patients were high for Nectin-4, TROP2, and also for HER2. So I think we will see some more publications coming out in this space. It's still an interesting area, maybe to parse out, are there particular subtypes that are more highly expressing of these particular proteins than others, and if that can be useful in the clinical setting. So PD-L1 is something I'm just going to put one slide in on. I think we're all very familiar with the PD-L1 story. We're not required to do the testing for these metastatic cancers, certainly in the US or Canada. I know that differs by jurisdiction, and there are some testing requirements in Europe and perhaps elsewhere in the world. But suffice to say, there was a lot of interest in PD-L1 testing back in 2016 or so, when this whole era of the immune checkpoint inhibitors really exploded onto the oncology scene. And we know that PD-L1 testing is fraught with many challenges, namely that we have different manufacturers who have different drugs that use different assays for. The assays are interpreted differently depending on which antibody is being used, and the cutoffs are different as well. And just to share this with you, this is an example from, I forgot to put the citation in, but this is a paper we published in the American Journal of Surgical Pathology a couple of years ago, where we looked at a variety of different PD-L1 antibodies on sequential TMA sections, and you can actually see how different the staining can look depending on the antibody used. And while there was a lot of excitement, it's now known that probably less than 30% of the patients will respond to these immune checkpoint inhibitors in the urothelial world. And the other thing that's of note is that it was realized that many patients who were PD-L1 positive or PD-L1 high, as you can see from the waterfall plots here, not all of these patients will respond. And conversely, you will have patients who are PD-L1 low or negative who may respond. So as I said, no requirement for us to do the testing for these advanced urothelial cancers in North America, but that is a little bit different elsewhere in the world. And then mismatch repair testing. Mismatch repair testing is something that we are mandated to do for upper urinary tract tumors in the province of Ontario. So all upper tract cases, irrespective of history or age, etc., we are now required to do mismatch repair immunohistochemistry testing. And that's to identify patients with Lynch syndrome. Mismatch repair deficiency in the bladder, however, is not that common. It's certainly less than 2% of cases where you will see it. But where mismatch repair testing may be important in context of urothelial cancers when you're dealing with metastatic or advanced disease. And this really came about from this publication a few years ago, looking at PD-1 blockade in tumors that were mismatch repair deficient. And this was one of the first papers, I think, that really looked at this concept of tumor agnostic testing. So you're not looking at the site of the tumor to enroll the patient in the clinical trial. Traditionally, what we see with clinical trials is someone has lung cancer goes into a lung cancer trial, someone with pancreatic cancer goes into a pancreatic cancer specific trial. In these more basket trials, you're enrolling patients with multiple cancers from multiple different sites. And the common theme is the biomarker expression. So in this particular study, they looked at patients, and again, heavily pre-treated with multiple lines of therapy to look at their mismatch repair deficiency status. And if they were MMR deficient, then they would be approved for use of an immune checkpoint inhibitor, which is pembrolizumab, and that resulted in that FDA approval. So you may be requested to do mismatch repair deficiency testing, but it's not in the primary bladder setting. It would be in the context of a patient who has widespread disease, who failed multiple lines of systemic therapy, and it's not for identifying Lynch in this setting. It's again to confer candidacy for immune checkpoint inhibitor therapy as a systemic therapeutic option. Lots of novel markers that are coming out in clinical trials. So we'll see more on these in years to come. And then, as I've already said, we're still using a lot of chemotherapy. About 50% of patients may not be eligible for chemotherapy based on performance status. And we know not everyone responds to chemotherapy, and it is a toxic therapeutic strategy. So it would be a great idea and very sensible if we could identify people who will likely respond to chemotherapy and those who we think will not respond. And that's where this idea of biomarkers of chemotherapy response could potentially be coming down the line. It's hard to talk about anything molecular in bladder without referencing our luminal, basal, and consensus molecular classification that we know about from the muscle invasive bladder cancer setting. This is a very familiar image to everyone. And essentially, the consensus molecular classification for muscle invasive bladder cancer was put together to amalgamate and to get some harmonization amongst the different systems that were out there. And at a very high level, we can talk about luminal and basal bladder cancers, and also a smaller group of neuroendocrine. And the reason this was of interest is that it was recognized that particular classes may harbor specific oncogenic mutations that may be targetable, and some of them also have specific histologic features. And interesting work showing that different molecular classes may have some clinical relevance. This work came from the Lund group, which has shown that patients who are basal squamous subtype almost never have bone metastases, and those that have a particular luminal subtype called the genomically unstable often or very rarely have lung metastases. So there's some interest in exploring this further, and again, there may be some treatment relevance related to molecular classes. So patients who have FGFR, as we've already talked about, mutations may be eligible for FGFR-directed therapy. Patients with a lot of immune infiltrates may be more responsive to immunotherapy, etc. There is some real-world clinical trial that is ongoing. I think it's still accruing in the United Kingdom, called the Gusto trial, where they will test this hypothesis by prospectively enrolling patients into a subtype specific or selected care based on the gene expression profiling, and then they will follow them with surgery and adjuvant treatment to essentially see, can you do upfront gene expression profiling, and does that impact and contribute to personalized care in bladder cancer. So for the final 2 to 3 minutes, I just wanted to talk about this entity, and everyone who reports a lot of GU knows bladder versus prostate. You think it's going to be straightforward, but you get these high-grade tumors at the bladder neck, and it can be a high-grade urothelial or it could be a high-grade prostate. They can look the same. So there are many different phases of prostate cancer, and often the challenge in prostate cancer is usually grading, not making the diagnosis. There are many different phases of bladder cancer, and the challenge here is often recognizing subtypes and divergent differentiation. However, sometimes it can be challenging to differentiate the two, and as we know, the treatment options are very different. And this is a case I had about 4 years ago. It was a very typical case, an 85-year-old man who presented with hematuria, had a background history of BPH on a TERP. They scoped him, he had a tumor at the bladder neck, he underwent a TURBT, and it showed bladder and prostate tissue. This is one representative image of the chips so almost everything was consisting of tumor, and it looked high grade and pretty solid. And I have to say, when I looked at this particular chip, I thought, okay, this is a high-grade urothelial carcinoma. I think this is surface urothelium. This is invasion in the lamina propria. I can appreciate some atypical mitoses. I'm starting to see little clusters of mitotic figures and these larger pleomorphic hyperchromatic nuclei that are dotted throughout. So I thought, yes, high-grade urothelial carcinoma. But of course, because it's the bladder neck, I did some immunos. This was the CK7, which was positive, but had a slightly funny pattern. I also did prostate markers, and this was the NKX 3.1. So essentially, this was a tumor that showed CK7 expression. It was focally positive for high molecular weight keratins, negative for GATA3, but also showed prostate co-expression. And this was signed out as a grade group 5 or Gleason score 10 prostate cancer, noting this diffuse urothelial-like morphology with aberrant keratin expression. And I thought that was that. But then over the course of that summer, I got several more cases similar to this. We saw cases that popped up in lung biopsies, prostatectomies, and liver biopsies. And the common theme here was this urothelial appearance. And as you can see on this particular TERP case here, aberrant protein expression. So there was P63, some CK7, a lot of 34B12, a little bit of synapto, but also ERG and NKX 3.1. In the lung biopsy, this was a challenging case. This person had a history of urothelial, and the lung pathologist correctly did CK7, CK20, and they were positive, but thought they would still do lung biomarkers anyway. And part of our biomarker panel looks at RNA fusions, and the molecular folks picked up a TMPRSS2 ERG fusion, and we went back and stained it, and it was ERG and also NKX 3.1 positive. So just to note this very urothelial appearance at quite different sites within prostate, within bladder, but also at metastatic sites. So we put together this as a case series that we published late last year. We had 12 cases, and the common thing here was these were all high-grade prostate cancers that had aberrant keratin expressions. Many of them had very diffuse urothelial morphology, which is deceptive, and some of them had been pre-treated, but some of them were de novo. So just to bear in mind that there's this concept, particularly in a heavily treated high-grade prostate cancers, that you can often get aberrant protein expression, and it's a good idea to use a panel of markers, so both urothelial and prostatic markers, to help resolve that differential. And just in case you think this is some sort of weird, unique Toronto problem, I promise you it's not. This case was shared with us recently by our colleague, Dr. Ankur Sangoy in Stanford, so not from Toronto, and he had a similar challenging case where a patient with prostate cancer with epidural tumor who was CK7 and 20 positive, but also expressing NKX 3.1, and this person had also previously been treated. So I'm going to wrap up now. I would like to thank all of the members of the working group for the Florence Consensus meeting who put together obviously the pre-meeting survey, and obviously were involved in putting together that paper that's published. And a big thank you to 2 people for all of the Sunnybrook work. So Jennifer Noyne is our amazing chief resident who is going to go on and pursue a career in GU pathology, and she was the first author on both that paper from Pathology Research and Practice and the recent FGFR work, and also our research program manager, Dr. Katerina Olkovnitzel, who does a lot of our wet lab work and statistics and bioinformatics. So I'm going to finish now, and thank you for your attention. I'm sorry, Dr. Walker, I'm almost at time, but maybe we can take a few questions.
Sure. So we'll keep it pretty quick. I want to respect everybody's time. I think there's some questions kind of about what might be on the horizon for maybe the grading or diagnostic criteria of low grade or high grade papillary, which I know you have interest in. So maybe a few words about that.
So I would direct anyone who's interested in grading to the Excellent ISUP Presents webinar that Steve Shen did, which I think was earlier in the summer. So that should be available online for everyone to take a look at. But essentially, we're talking about two-tier versus three-tier grading. Three-tier grading is quite common in Europe versus the two-tier WHO 2004, which is much more common in North America and other parts of the world. I think there's a lot of data, which is mainly European, showing that particularly for the high-grade cases, there's a lot of clinically heterogeneous behavior, and that there would be merit in separating those into sort of the extreme high grade, which is sort of the grade 3 in the WHO 73, and the less extreme high grade, which is often sitting on the border with some of the low grade cases. So I think that's what people are asking about. I'm not aware if there's any changes coming down the line in terms of that. I know the European Association of Urology guidelines recommend you dual grade, so you use WHO 2004 and 73, and there's definitely been a big push amongst the European urology community for people to report that way, but the AUA recommends the WHO 2004, so very jurisdiction dependent. I'm sure we will see more. It would be nice to see more studies coming out of places other than Europe on that, though. So maybe that will inspire people to do some work.
Great. An interesting question from Arno about sort of the combination of histologic features and biomarkers for molecular subtypes. I'll try to read it. I don't know if you can see it, but he comments that CIS usually has a luminal phenotype where it's keratin 20 positive and CD44 positive, but some papers have mentioned CIS with more of a basosquamous phenotype that's keratin 5 positive and keratin 20 negative. And sort of does this suggest a basosquamous CIS profile, and should that be distinguished from squamous metaplasia?
Oh, wow, that's I'm reading it now. There's a lot in there. Thank you, Arno. Yes, it normally is luminal phenotype. That is correct. To be honest, I don't actually do these markers on CIS, so I don't actually know in a real world practice as opposed to outside of a study how common this basosquamous may be. Honestly, for me, CIS is usually a morphology diagnosis, so I don't rely on immunohistochemistry. So I don't have a lot of experience with that, but you're right, it is usually a luminal phenotype. And dysplastic squamous metaplasia, well, I'm not entirely sure what a basosquamous phenotype of CIS looks like, because maybe I just have never diagnosed it. I'm not sure how you would distinguish it, but I don't rely on immunohistochemistry. I think CIS is still a morphology diagnosis. Squamous metaplasia usually has that acquisition of very pink cytoplasm. It has those harder edges. If you have a 6DX lens on your microscope, maybe you can see the intercellular bridges. So I think it would be a morphology alone to help distinguish it, as opposed to an IHC panel.
Yeah, I agree. I also hardly ever use IHC on in situ lesions, but I do think it raises potentially an interesting corollary where I have on occasion seen non-invasive urothelial carcinomas that have sort of a variant or subtype histology to them, and we don't really know what that means, what the significance is. I think micropapillary is one we're probably all familiar with, but I've seen ones that look a little bit plasmacytoid, and is this something where there is the ability to develop subtypes even in a non-invasive component? So definitely raises some interesting questions. I think in interest of everyone's time, we'll go ahead and call it there. Thank you all for attending and your great questions. We are scheduled for next month to have Dr. Henning Rice present on urachal carcinomas, which is also a continuation of one of the ISUP consensus meetings. So we'll have an announcement going out shortly for that. So thank you, Dr. Downs, and thank you all for attending today's ISUP Presents.
Thank you, Dr. Welker. Have a good day, everyone.
Bye.